Well, this is an extraordinary meeting. I have to say, I go to a lot of meetings, and I can't. You guys really have a really unique experience here, and it's been a thrill to be here. And why would you want to get a lung biopsy? But let me convince you in the next 20 minutes why it's absolutely essential for life. Okay? I'm as conflicted as I was yesterday. So the first question is all pulmonary fibrosis the same? So this is a patient of mine, 45-year-old lady who's quite ill, comes in with a progressive fibrosing lung disease. As you can see here, she has extensive traction bronchiectasis in the lower lobes, and walking down the hallway, oxygen saturations in the high 70s. She's been treated with antibiotics, absolutely no response. And no subpleural honeycombing, though. You see that, Rick, right? There's no subpleural honeycombing there. It's absolutely essential, okay? So what does her lung biopsy look like? So she has this very homogeneous pattern of fibrosis. All the pink stuff is collagen. There's a lot of inflammatory cells in there as well, but when you drill down here at higher power, these interstices are just uniformly thickened with collagen. So I like this case because when you show this to the radiologists, they go, yeah, that's fibrosis. The kind of fibrosis like doesn't get better, right? Exactly. So she turns out she's got an underlying connective tissue disease. I don't know what you call it. Every test you order is positive. So a rheumatologist can't actually give you a name, but you know, as a pulmonologist, as Dan knows, what do? We give steroids, right? And voila, she's cured. So here's a fibrosing lung disease that's lethal if untreated, that's actually completely reversible. Now you contrast that with what I talked about yesterday. This fibrosing lung disease in which you have this really peculiar pattern of fibrosis, that really begins at the pleural surface there, that you never want to biopsy. You never want to biopsy this because you're only going to get an air leak and you have nothing to offer the patient. And remember what the biopsy looks like. You've got normal lung interspersed with areas of collagen deposition. And this is what it looks like in the very early stages. Completely normal lung, collagen, established scar, and then this is the leading edge, as we like to say. This is where the action is. So what I want to spend the next sort of 15 minutes talking to you about is what's in between those two extremes and why it's absolutely essential to get a surgical biopsy. And the reason this is so important is because some of my idiot colleagues have now been writing recommendations that we don't need to do surgical biopsies anymore, that we can look at the CAT scans and we can say that this patient has a lethal disease. And what I'm going to show you in the next 15 minutes is why we're not so good at doing that and why we still need to get surgical biopsies. So it really boils down to this. Do they have pulmonary IPF, idiopathic pulmonary fibrosis, or as I told you yesterday, this weird term called UIP, or do they not have it? Okay? And the reason it's important is if you have IPF, you need to get into a pulmonary rehab program, particularly in the state of North Carolina. You need to lose weight. And we have clinical trials. We've got a lot of clinical trials that we can enroll these patients in. Some really exciting phase 2 trials. We've got phase 3 trials that are fully enrolled. We may have some drugs. And they need to be seen by a transplant program. Absolutely. If they don't have IPF, you can potentially cure them. But distinguishing between these two is incredibly difficult. So here we go. This is a 65-year-old gentleman. This is sort of my index case. I had been at Duke very long, maybe 6 months, and you know it's important when you get a referral from the University of North Carolina, okay, because that doesn't happen very often, all right? And this was a gentleman who came over, in fact, to be honest, because his wonderful pulmonologist wanted to get a lung transplant, and things are a little quicker at Duke than they are at North Carolina. Not necessarily better, but a little quicker. And so this fella here basically came in with this CAT scan. Exertional breathlessness over about 6 months. Antibiotics hadn't gotten any better. Was on some steroids, wasn't getting any better. Didn't seem to have a clear-cut systemic disease. He had an ANA of 1 to 640, but you never know what to do with that. He was on a statin and had a mildly elevated aldolase. And this is what his lower lungs, so is this IPF or not? So he was pretty sick. When he walked down the hallway, he desaturated. So we actually started, referred him for transplant, and he had awful GERD, did a Nissen in him, and I put him on some he was on low-dose steroids. I added in a second agent just sort of to try to keep things going, you know, while we got the transplant evaluation going. And then, lo and behold, over the next sort of 6 or 9 months, he got a little bit better, which really, really surprised me. And then he was treated him for about a year, year and a half. He started to get some complications from his medication, so I sort of weaned him down, and he started to get worse. So I had a real decision there. So does he have IPF? Does he not have IPF? You know, if he really has IPF, I probably need to get him off this stuff and just, you know, get him transplanted. But if he doesn't, maybe I need to switch his immunosuppressive therapy. Maybe he was on azathioprine at the time. Maybe I need to switch him to Cellcept or something like that. So we biopsied him. And this is what we found. So there's normal lung in here. So by definition, this is what the pathologist will call a variegated pattern. Variegated just means it all doesn't look the same. But out here at the periphery, we see established scar. But then as we start to drill down a little bit more in this, at the leading edge, what we see here is this is the lesion here. This is this fibroblastic focus. Now look at higher power. What we see here is normal lung transitioning to this process, and we see all these blue cells around this. So surrounding this sort of cancer-like lesion, if you will, this fibroblastic focus, is this collection of inflammatory cells. And so what we ended up doing was switching his immunosuppressive therapy, and he's now 5 years out, not on oxygen, did not need a lung transplant. He would have been called IPF by 9 out of 10 pulmonologists, radiologists in the country. So this is a 73-year-old gentleman. Actually, you look at this CAT scan, this is subpleural honeycombing. He had been treated with immunosuppressive therapy, progressed, and got transplanted at Duke. A 73-year-old guy with 1 kidney got transplanted. He's now 3 years out, doing great. I had to twist a few arms to get that one done, but I'm glad I did. And look at this. This is the biggest fibroblastic focus we've ever seen. This is at his explant. There's no inflammation around there. Really no inflammation. So this is true IPF. Here's another 68-year-old patient, okay? Same exact symptoms, exertional breathlessness, cough, you know, just retired, enjoying life, doing more exercise, finding themselves more limited. Here we've got these peripheral reticular opacities. Look at this biopsy. So we have a little bit of normal lung, and there's another picture here, a lot of normal lung. But then you have this abnormality here where, again, there's this sort of, you know, expansion of mesenchymal tissue, which is basically activated fibroblasts or myofibroblasts. But surrounding is this collection of these blue cells interspersed with normal lung. So again, this would be called IPF. Patient is 5 years out on immunosuppressive therapy, judicious, low dose, doing well. 68-year-old person. They're all, I mean, it's like almost like a broken record here. Again, look at this peripheral reticulation. Is this honeycombing? It sure is awfully close, right, Rick? You buying it? You're buying it, exactly. Put the patient in a clinical trial, get them on a transplant list, something like that, if they want to go down that route. And look at this. This really looks pretty convincing for honeycombing. So many times, this patient in the sort of where we're at in the pulmonary world would not get biopsied now. This patient would not get biopsied. They'd be told they have IPF. Look at the biopsy. We have normal lung. Here we've got some areas of what we call this other form, nonspecific interstitial pneumonia. And then we've got, this is again, this variegated pattern, normal lung, but at the transition zones, we have these blue cells, these collection of blue cells. Again, look at this here. Normal lung, blue cells in there. Again, this patient's 3 years out on low-dose immunosuppressive therapy, has not progressed. So, is all fibrotic lung disease the same? So, progressive disease, needs transplant within 3 years or dead. Alive and well, without oxygen for 5 years. Can you tell the difference between these two? I can't, and I spend all my time looking at these things. So here's just some additional pictures from some of these types of patients where we have normal lung with these. So we began to wonder, is there a subset of IPF? And you know, a lot of IPF docs have said for years that there's about 10% of the patients that seem to do okay with immunosuppressive therapy. And you can never figure out what that 10% is. But again, just looking at a few more pictures, and then I'm going to show you what we did here. This lesion here, there's this fibroblastic focus, and this is the high power of it. So there it is, and look at this collection of these cells. And this is sort of the money shot here. So we came up with this idea that maybe there's this sort of indeterminate form, okay, of a UIP pattern, which just means there's normal lung in there. There's some honeycombing, microscopic honeycombing. There's fibroblastic foci in there. But you have, at this leading edge, fibroblastic focus, you've got this sort of collection of inflammatory cells. And we sort of came up with this term for it. Actually, it was based on my good friend Kevin Leslie, who's at the Mayo Clinic in Scottsdale, a wonderful pathologist, because he likes to distinguish in interstitial lung disease between blue and pink disease. Blue is always better. So we call this blue IP. In contrast, this is the fibroblastic focus from a patient who's gone on to need lung transplant. So refractory to immunosuppressive therapy. And you don't sort of see that. But it's not an all or none thing. There's a gradation. So we sort of call this 0, 1, 2, 3 kind of idea. So what we did was we went and looked at the biopsies done at Duke for interstitial lung disease or some post-transplant lung pathology, because we're really interested in the Boss lesion that Dwayne talked about. And what we did was we ended up sort of having 250 cases of from a practical standpoint. And we have 3 pathologists, and then we actually imported Kevin Leslie to come in, and we spent a long weekend looking at all of these things. And we came up with 81 cases that we were all agreed were variegated, which just means there's normal lung interspersed with collagen. And we wanted to look at those in more detail. So this was sort of this is sort of the spectrum of disease. And this you never want to see, unclassifiable. That means you can't actually come up with a reason why there's a scar tissue there, but it's a significant number. So of these 80 that were classified as variegated, we broke them down, and we did this in a blinded way, so the pathologists, because they rarely agree on anything. But actually, once we established criteria and they looked at it in a blinded way, sort of the majority of them were what we would call sort of typical UIP. But there was a subset that had this thing that we're calling blue IP. Now, does it matter? So we're still analyzing these data, but we have the top line. So of the 60 patients that we were all convinced had classic IPF, 30 of them are either dead or have gone on to transplant. Whereas in this subset of blue IP, only 5 of the 20 have. So it's not an incredibly large percentage, but you've basically found a group of patients that you can manage with judicious immunosuppressive therapy, and they won't go on to needing transplant. But the only way you can distinguish these is with a surgical lung biopsy. And so we're trying to get a sense of why this is. So we did some analyses where we looked for sort of different patterns of gene expression, when we just used sort of a chip that sort of distinguished inflammatory genes from genes that are involved in like cancer or proliferation. And what we see is a really neat demarcation between these patients who have what we're calling this inflammatory variant of IPF and more traditional disease. So we think there's a subset that is important to identify because you can help them with medications. So we're calling this non-idiopathic UIP, so to speak, or blue IP. Is this different from IPF? The HRCT, is a little bit more nebulous in terms of whether it has clear-cut subpleural honeycombing, but the VATS biopsy features, we've sort of identified these. It's a variegated pattern, which means there's normal lung, but at the pleural surface, there's a little bit more neovascularization. I showed you these mononuclear aggregates that are not embedded in the established scar. there's not as many of these bad fibroblastic foci, and there's not a lot of microscopic honeycombing. But immunosuppressive therapy may prevent the need for transplant. And you know, the problem is that with IPF, the data that are coming out are that that if you treat those folks with immunosuppressive therapy, they actually, more of them will die than if you do nothing to them. So it's really kind of an important clinical area, although granted, it's not, you know, a major problem. But in my world of ILD, it's a huge issue. So the take-home message, despite trends for relying on the HRC for diagnosis of fibrotic interstitial lung disease, the VATS biopsy remains a critical component of the management. The keys to success are, though, the proper surgical sampling, as we discussed briefly yesterday, the least involved regions, all lobes on whichever side is chosen, and stay away from the lingula. So where we're going with this is that IPF or not IPF, this is what we need to do for our patients with IPF. Keep them free of poisons, so if they need to transplant, they're more likely to do well. Get them in rehab, get them to lose weight, start training really for that big operation that they need. But if they have this variant, we can potentially prevent them from, and more importantly, I see a lot of patients who we diagnose in this who were never treated. And unfortunately, if you don't treat them, they will go on and progress. And so there's a subset of patients that are called IPF that we may be able to avoid transplanting. But VATS biopsy is the only way we can distinguish this. There's no blood marker. The CAT scan is not good enough. We need a surgical biopsy. So it's all about teamwork, and I had a great team at Duke, pulmonologists, pathologists, radiologists, and great thoracic surgeons. Kevin Leslie helped. And this last slide is for my good friend, Dr. Fines, because it is all about teamwork. And tonight is a really important game, Duke, Carolina, all right? Thank you very much.